Thank you so much for that kind introduction. And thank you, Dr. Nagarjuna and his team for inviting us here to talk on this. So my topic for today is EBUS sample collection and triaging, a lot to do with little. Please don't get offended when I say little, because I will show you that whatever samples that are sent to us, when they are processed and formed a cell block, how do they look actually? So the first question for the poll is, what is the appropriate liquid media used for collecting needle aspirates in EBUS TBNA? So these are the options: normal saline, 10% NBF, neutral buffered formalin, 95% alcohol, and the option D is depending upon the Rose diagnosis and type of investigation needed. It's a pretty simple one, I think. Oh yes, all of you are, like at least 50% of you are right. We need to put the media in accordance with the investigations which we require. So the second question of this talk is, how many minimum tumor cells are required in the cell block sample for PD-L1 testing in the setting of lung carcinoma? And your options are 50, 100, 150, 500 to 1,000. Yes, 1/3 of you all have correctly answered. It is around 100 cells minimum are required for PD-L1 testing. So I would not talk about EBUS, TBNA, and Rose, but to highlight the importance of this very important investigation, which has become a part of routine pulmonology practice. Rose is encouraged at EBUS EBNA according to our experience because it improves the diagnostic yield. It gives us additional sample for all the ancillary testing, which has become a part of the diagnostic guidelines in cases of lung carcinoma nowadays. And once N3 node is positive, you know the prognosis and the therapeutics of the patient. Now, this is very important that once we confirm a diagnosis on Rose, which may require anywhere between 2 to 3 passes at the maximum, we would require you to take at least 3 to 5 TBNA passes for the preparation of cell block and to collect the material for any ancillary testing, apart from the biopsy that will be performed to pick up biopsy samples for the histopathological diagnosis. Now, my talk will be concerning which media is suitable for collecting CB TBNA samples, what is CB or a cell block, how to actually make a cell block in a laboratory, what is the tumor adequacy that we describe in cell block, and what all can we do with the cell block. There are a variety of liquid media which are available to collect these needle aspirates, namely the normal saline, 95% alcohol, RPMI, and fixatives such as cytolite, which is alcohol-based, and 10% neutral buffered formalin. As I've already told you, the media to use depends on clinical diagnosis and Rose report and the investigations which are required. Normal saline, usually we collect the needle aspirates in normal saline when we require to do microbiological cultures and gene experts. Then flow cytometry also sometimes utilizes normal saline, although it's not the recommended media. Recommended media is the RPMI media. It supports the flow cytometry and cell cultures, but the disadvantage of RPMI is that it's not readily available at all the centers and it needs refrigeration. And the disadvantage with normal saline is that the cellular integrity is compromised in few hours. So if we want to prepare a cell block and we want to carry out the histopathology examination as well as IHC and ancillary molecular testing, we need to fix our cell block samples in 10% buffered formalin. It's a very readily available, inexpensive kind of media, validated for performing the tests, special stains, and IHCs. An important point to remember here when we talk of liquid media is do not use fixatives which have hard metals or harsh acids. Some of these Zenker B5, B+, Bowen's acid zinc formalin are the ones which interfere with the nucleic acids fragmentation and interfere with the DNA polymerases which are used as enzymes in the PCR testing. So if any of your labs are utilizing these fixatives for cell block preparation, kindly do not do them because it causes suboptimal preservation of the sample. Now, what is a cell block? It is actually nothing, but we are converting a cytologic material or an aspirate into a mini biopsy, and that mini biopsy is now being utilized actually as a biopsy sample, and it is processed and sectioned and stained and studied under the microscope as we study the biopsy sample. Now, the advantages of cell block is that it preserves the architectural details. It can be used to do many ancillary studies, and traditionally, the cell blocks are being utilized for molecular tests because they recapitulate the formalin-fixed paraffin-embedded tissues, which we receive as biopsy sample, and it increases the diagnostic yield of the TBNA aspirates. There are 3 major steps which are involved in cell block preparation. First, you rinse the material, aspirated material, into a sterile container. Then you fix the sample in 10% neutral buffered formalin, and then you make a pellet or a clot. Before we make a pellet or a clot, we have to add some clotting agent in that sample, which is done at the lab services center. The samples which are in NS or RPMI, plasma or thrombin can be used as a clotting agent. The samples which are obtained in cytolite or formalin fixatives can be added with agar, histogel, or egg albumin to increase the yield and prepare the clots. Then there's another colloidal bag technique which utilizes the test tubes already having some polymers linked to it, in which the cellular material can be trapped. So in our lab, the workflow is the rinsed aspirated material or the needle washers, which are obtained from the bronchoscopic suite, is fixed in 10% formalin, centrifuged at 3000 RPM for 15 minutes. Then we discard the supernatant and equal quantities of alcohol, distilled water, and 10% formalin with 1 to 2 drops of glacial acetic acid, which helps in lysing the blood. After mixing it well, you can add a clotting agent, egg albumin or agar, refrigerate at 2 to 8 degrees Celsius, and take for tissue processing. This is the photograph depicting, this is the sample for cell block preparation. This is how we transfer in a test tube. After centrifugation, you can see there is a clear supernatant and a blood clot has been prepared. And this is how, finally, the tissue that comes on my table looks like. So I would not say it's a very less tissue, but I would say that, of course, the large quantity of material that is procured is transported to us, and then what we get is this tiny 0.8 centimeter tissue, and then, we have to actually triage this tissue, and it's extremely important for us to know what all we can do with it. There are some pre-analytical factors which affect the outcome of ancillary testing on the cell block. One, I already told you, the use of appropriate liquid media. Another very important thing is that if you are not very sure, or if you are not transporting the cell block needle aspirate, which you have taken from the EBUS TBNA, into 10% neutral buffered formalin, and you're directly transporting it to the lab, please make sure that the storage conditions of that cell block sample or the needle aspirate is good. You have to refrigerate that sample as early as possible at 2 to 4 degrees Celsius. And in next 4 to 5 days also, the integrity of the sample will not be compromised. If at all you don't have any alcohols or neutral buffered formalin available with you. And third is the type of fixative which you are using, which you've already discussed. So this is in short the Rose triage pathway which we follow. The aspirates, if they are adequate, showing malignant cytology, have to be submitted as cell block. If they're showing granulomas, TB culture has to be carried out in that. If there are reactive lymphoid tissue, or it is suggesting a lymphoma diagnosis, the clots can be prepared for cell block, and this can also be submitted in RPMI media for flow cytometric analysis. If it's inadequate or non-diagnostic, more passes have to be taken. So this is again, in short, the triaging of the EBUS TB and aspirate. One thing I want to add here is that before we add a neutral buffered formalin to the cell block samples, which you are going to send us for preparation of cell blocks, make sure that we at least make 5 to 6 unstained smears, which are air dried, so that if in case our cell block does not show any definite evidence of malignancy or the sample is not adequate for ancillary testing, those air-dried smears can be used and triaged for carrying out the molecular testing. Because once the sample of cell block has been transferred to neutral buffered formalin, the preservation of the cells on the cytology samples can be hampered, and we may not be able to retrieve any of those material for any molecular testing. Now, how much little is enough? So according to CAP, if adequate quantity of diagnostic material is there in the cell block, the quality of the material is similar to, if not superior, to the surgical pathology biopsy samples. So molecular studies usually require an absolute count, and usually each institute establishes its own cutoffs, ranging from 500 to 1,000 cells, and that is regarding the whole immunohistochemical panel as well as molecular testing. Perhaps, but for PDL1 testing, this cutoff has been defined as 100 cells. So these are all cases where, cell block preparation has been so helpful to us. First was a case of definitely adenocarcinoma that was a relapse after lobectomy of the patient was performed, and it was TTF1, napsine, CK7 positive. Second that you see is a squamous cell carcinoma, P40 positive. Third was a small cell carcinoma positive for synaptophysin chromogranin. A good IHC staining requires good preservation of the cells in the cell block, and so it's very important that we refrigerate the sample, or we should put neutral buffered formalin if the cell block has to be prepared. These are some of the cases of metastatic malignancies. First is metastatic carcinoma, primary breast origin, GATA3 positive. Second is a metastatic carcinoma, prostate origin, positive for NKX 3.1 and PSA. It can be very well confused with a small cell carcinoma, so it's extremely important to carry out IHC. Then third is a metastatic carcinoma, primary ovarian origin, which was positive for PAX8. Not only PAX8, metastatic malignancies in cases of ovarian carcinomas, metastatic tumors in case of ovarian carcinoma, which is a recurrent or relapsed disease, require molecular testing nowadays. So with emerging biomarker testing in almost all solid tumors as well as metastatic malignancies, it's extremely important that we have more and more tissue on histopathology so that we can utilize it for the IHC and the ancillary studies. Next couple of slides would be only on lung cancer histologic categories. We all know that 85% of the lung cancers are non-small cell carcinomas. Nowadays, the whole world is facing...
2 minutes to have.
Lung cancer is the most common cause of death among men and women the world over. So it's very important that biomarker testing has to be utilized on the cell block samples and whatever samples we collect with EBUS TBNA. The evolution of lung cancer from the morphologic point of view to the IHC and the molecular has been witnessed by one and all in the last 2 decades. This is a small algorithmic workup of the non-small cell carcinoma. The most 2 important IHCs which we apply in our setting is TTF1 and P40. Once the histologic subtyping is done, you do not need to apply any IHC marker. And if histologic subtyping cannot be done, TTF1 and P40 have to be applied. After you diagnose on IHC, the next molecular workup is done. So we can see that adenocarcinoma has a lot of targets now, EGFR, ALK-ROS, PDL1, the most important ones. So these are some of the NCCN guidelines. In all non-small cell lung carcinomas now, we are doing EGFR mutation, ALK-ROS, BRAF, NTRK, MET, RET. Testing should be conducted as a part of broad molecular panel. So emerging targets has actually put us in a very important position as a pathologist, and it's extremely beneficial for us to switch to NGS-based assays to evaluate all these biomarkers rather than doing a single gene, because NGS has a very high sensitivity and specificity. Low volumes of samples can be used for this testing. Increased number of alterations can be detected because it's a mass DNA sequencing that we are doing in NGS-based assays. It's actually the circulating tumor cells or the cell-free DNA, cfDNA, which we utilize in NGS panels. So the issue of heterogeneity is also counteracted. Over a period of time, believe me, it will become very cost-effective and also will give results in a very short time. But the disadvantages are it needs specialized software and expensive in sub-developing countries.
Ma'am, please wind up.
This is the last slide of my presentation, which I would try to bring a change in perspective that liquid biopsy is now providing sufficient material for the NGS assays. It can be repeated serially to monitor the response. It's non-invasive, reduces the costs and risks of complications, and the genomic abnormalities detected by the plasma or biopsy have proven to be equally actionable. Thank you so much. This is my team, cytotechnologists and the pulmonologists.
Thank you.